Before I begin, I'd like to acknowledge the traditional custodians on the land on which I'm presenting this talk, the Dharwa people of the Dharwa Nation, and I extend my respects to elders past, present, and emerging. I'd also like to thank the organizers for giving me the opportunity to present my talk today. So the title of my presentation is Immunological Dysfunction Persists Following Initial Mild Moderate SARS-CoV-2 Infection. And we published some of this work earlier this year with some new data now that I'm presenting as a potential driver of the condition that is long COVID. So coronavirus disease 2019, or COVID-19, as most people know, the illness caused by severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is characterized by a wide spectrum of clinical severities in the acute phase, ranging from asymptomatic to severe fatal forms. A proportion of patients surviving acute COVID-19 develop post-COVID syndrome, a condition that encompasses various physical and neuropsychiatric symptoms lasting longer than 12 weeks. This condition is also known as chronic COVID syndrome, post-acute sequelae of COVID-19, and long-haul COVID. Persistent symptoms 6 months after hospitalization was observed in 70% of discharged patients in a study by Huang et al., with the most frequent symptoms reported being muscle weakness and fatigue. Amongst community-managed COVID-19 cases, prevalence of persisting symptoms is lower but remains higher than might be expected given the severity of the initial illness, affecting about 10 to 30% of individuals at 2 to 3 months post-infection. The spectrum of post-acute sequelae of COVID-19, henceforth denoted as long COVID, is broad and encompasses more than 50 symptoms, although characteristically manifests as severe relapsing fatigue, often accompanied by dyspnea, chest tightness, cough, and headache. The underlying pathophysiology of long COVID is poorly understood, and there is currently little evidence defining the mechanisms of systemic inflammation following COVID-19 infection, and any immune correlates of ongoing symptoms have not been described. The EGDAP study, it was a study that we developed to answer this question. It is a prospective cohort study of post-COVID-19 recovery. It was established during the first wave in April 2020. We recruited 147 participants with confirmed SARS-CoV-2 infection. Majority of these following testing in community-based clinics run by St. Vincent's Hospital, Sydney, with some patients also enrolled with confirmed infection at external sites. We defined long COVID, and this was at 4 months, so around August 2020, where patients were defined as long COVID based on the presence of either one or a combination of the following symptoms, which included fatigue, dyspnea, and chest pain. And this was actually more stringent and narrower than the WHO definition following the Delphi survey a year later. So this table summarizes the cohort characteristics that we used. So ADAPT were composed of 2 arms. The first were patients that developed long COVID, about 21% of the patients, N equals 31. And then we age and gender matched a control group, which we call asymptomatic match controls. It is important to note that 8 of the long COVIDs were hospitalized and were clinically defined as having severe disease, and 2 within the match control group. We also had a unique cohort of endemic common cold coronavirus infected patients, as well as 2 unexposed cohorts. So from our previous findings, we showed that there was a strong suggestion that there is ongoing sustained inflammatory response following mild to moderate acute COVID-19 infection, and it is not found in infections with other prevalent endemic coronaviruses. In those with persistent long COVID symptoms, this was distinct from asymptomatic convalescence. There is a sustained increase out to at least 8 months in highly activated myeloid cells, particularly monocytes and plasmacytoid dendritic cells, that likely contributed to the sustained elevation of inflammatory cytokines, particularly type 1 and type 3 interferons, despite the majority of the cohort suffering initial mild moderate illness. Further, there was evidence of sustained activation of the adaptive immune system, manifesting in perturbations of both the memory and the naive effector cell compartments, with an absence of unactivated naive T and B cells and an increase in the checkpoint inhibitors or exhaustion markers PD1 and TIM3 on CD8 memory T cells. So this widespread activation signature is also reflected in the identification serum levels of interferon beta, interferon lambda 2/3, interferon gamma, IL-6, and PTX3 as the best features that most strongly associate with long COVID. The drivers of this activation, however, require further investigation, but possibilities include persistence of antigen, whether it's an autoimmune driven phenomenon, or a reflection of damage repair. And the rest of my talk will be focusing on whether the persistence of antigen is the driver of long COVID. So we wanted to know at initial infection whether there was a difference in the viral load between the two groups. As you can see here, the CQ values for the envelope gene that was measured from the swab was actually much lower compared to the match controls, but this was not significant. And the same was seen with nucleocapsid gene, which suggests that the long COVID group actually had no difference in initial viral load compared to the match controls, and the majority of the patients had mild moderate illness. Next, we wanted to see if there was persisting serum nucleocapsid proteins, and the majority of the cohort, as you can see here, did not have any detectable nucleocapsid protein within their serum. Only 2 in the long COVID, 3 detected in the matched controls, and this was not significant. However, when we measured neutralizing antibody titers in the serum, we found that there was an elevated neutralizing antibody level at 3 months and 8 months within the long COVIDs compared to the matched controls, and this was statistically significant. When both cohorts were fully vaccinated, the neutralizing antibodies increase, and no difference was found between the two groups. So it'd be interesting to see at the later time points, like such as 2 years, whether these level fluctuate or not, and whether ongoing antigen persistence is still causing the elevation of neutralizing antibodies. Also importantly, when we remove those severe patients, 8 from long COVID and 2 from match controls, the pattern remains the same, so it's not skewed because of symptom severity. When we also measured SARS-CoV-2 reactive CD4 T cells based on the cell surface expression of CD25 and OX40, and these activated immune markers have been used quite extensively to detect SARS-CoV-2 specific T cells. And you can see, shown in the blue, spike-specific responses are much higher in long COVIDs compared to match controls at both 3 and 8 months. RBD was only significant at 3 months, but nucleocapsid was still significant at 8 months in the long COVIDs compared to the match controls. And this was similar with their CD8 response as well. Nucleocapsid remaining higher at 8 months. And then post vaccination, there was no real difference between the spike or the RBD responses as the match controls were vaccinated, similar to the long COVIDs. However, nucleocapsid remained higher in long COVID compared to match control, and this is at the 18-month time point as well. A similar pattern was seen with CD8 responses. So to summarize, there was no difference in initial viral load or serum nucleocapsid concentration between long COVIDs and match controls. However, there was a higher neutralizing antibody titer found in long COVIDs compared to match controls, as well as elevated CD4 and CD8 responses at 3 and 8 months, with persistingly higher nucleocapsid responses post-vaccination. And it does suggest that there is ongoing persisting antigen within long COVIDs that is causing immune activation in the form of neutralizing antibody titers and activated SARS-CoV-2 specific T cells. So future directions, we want to see whether or determine whether there's fragmented viral proteins in innate cells. There have been 2 to 3 publications that have shown evidence of viral proteins inside monocytes, for example. So we'd like to have a look at this within our cohort. Also, we'd like to have a look whether there is persisting SARS-CoV-2 RNA or protein within tissue, particularly the gut, as SARS-CoV-2 RNA has been found in stool samples from patients much further beyond convalescence, a few months after recovery. So I'd like to thank all the people involved in this work, particularly Professor Tony Kelleher and Professor Gail Matthews, who led the study, David Darley, who was my first co-author and also helped with all the clinical work, Professor Greg Dorr, Annette Hal, Vera Clem, Mi Ling, Stuart and Anu for doing all of the neutralizing antibody work, collaborators at the University of Melbourne, as well as Dan Wilson, who did all the mathematical modeling for us. Thank you for giving me the opportunity to give this talk.